Thanks, dear colleague, dear chairman. Thanks for the invitation in this interesting session. And I would start some words on the epidemiology and the risk of sudden cardiac death at different ages. As you know, in young, the prevalence is relatively low, but as you can see from this slide, in the adolescent, in the puberty, the percentage is relatively high. What about the epidemiology in the United States? But I would like to underline the data in Italy. In Italy, as you can see, 1,000 sudden deaths occur in people under 35 years. And this is the well-known relationship between sport and sudden death. This is the focus on the debate, a different opinion, and I think that the screening for sudden cardiac death is a complex argument, and I would like to focus on this different aspect: how, when, and who. How? This paper reported the polling results of a vote. As you can see, a vote from Italian physician, American physician. As you can see, 74% of Italian physicians vote that screening should be required and should include a history, physical examination, and ECG. Otherwise, the American people, physician, only in 45% vote in this way, and 20% vote that the screening should not be required. And this is the Canadian experience. In this slide, you can see also the reason why not using ECG, not evidence-based, not enough local expertise, not cost-effective, and so on. This is the Italian experience. From 1982, the Italian pre-participation screening is mandatory, and as you can see, a young competitive athlete must undergo family and personal history, physical examination, and 12-lead ECG, and eventually other examination in order to evaluate the clinical situation. And this is also the trend of mortality that we observed. This is the well-known paper of Corrado and the co-worker. What happens in mortality before and after the law, a huge decline in mortality in screened athletes. And this slide showed the differences, the comparison between the Italian region, Veneto, and another USA region and Minnesota. As you can see, in the 90s, there was a higher percentage of sudden cardiac death in Veneto than in Minnesota. In Minnesota, the percentage remained equal on time, and in Veneto decreased significantly. And this is the suggestion of the major international sporting federation for the pre-participation cardiovascular screening that include ECG. Only the American Heart Association does suggest this inclusion. This is a slide reported the experience in Canada with a different approach, with a general questionnaire and a dedicated questionnaire, but also the ECG is present, and the author conclude the ECG identified most of the positive cases irrespective of screening strategy used. And this slide demonstrated the high sensitivity of ECG in the diagnosis of electrical abnormalities. And you can see on time there was a different modification of the criteria, of ECG criteria in athletes in order to increase sensitivity and specificity of this examination. And this paper is a meta-analysis, and from this meta-analysis, the sensitivity and specificity of ECG was 94-93% respectively, history 20% and 19.4%, and physical examination 9% of sensitivity only and 97% of specificity. This meta-analysis shows that the ECG is the most effective strategy for screening for cardiovascular disease in athletes, and the use of history and physical examination alone as a screening tool should be re-evaluated. When this is a problem, I know that the chair and our pediatric cardiology, and this slide demonstrates the problem of screening the children and this review, this meta-analysis reveals the lack of studies in the field of sudden cardiac death prevention in children, and lack of a clear definition and agreement contributes to the shortage of consistent data. With regard to ECG interpretation, biological age is probably the most relevant confounder because the end of puberty corresponds to the time when ECG becomes similar to an adult ECG. The ECG evaluation and the phenotypical manifestation of sudden cardiac death pathologies in children differ importantly from the adult athlete. And therefore, for this reason, the personal and familial history and the physical examination should remain the cornerstone in the risk assessment of sudden cardiac death in children. The last point, as you know, is the definition of an athlete, while still debated in adults, is highly controversial. But I take for me this consideration for Meyerberg. We know that many children, adolescents, and young adults participate in various levels of play, physical activity, non-organized competitive sport, and intensive physical conditioning programs. More than 25 million children and adolescents who do not participate in school-related sports teams but participate in various physical activities will be overlooked if ECG screening is limited to athletes. Accordingly, it can be argued that the rationale for ECG screening for competitive athletes should be extended to all children, adolescents, and young adults, as the logistics of cardiovascular screening are developed for the athlete population. And in this setting, I would like to remind this paper. This is a United Kingdom experience on more than 7,000 non-athletes. As you can see, this study demonstrated that 1 in 5 young people have group 2 ECG pattern. The uncommon and training unrelated ECG changes. And what about our experience? Our experience in cooperation of the Italian Foundation and the Circulation and the Ministry of Education in Italy on more than 16,000 students screened by ECG in 10 Italian regions, in 179 schools, in high school. The screening provides the medical history questionnaire, blood pressure measurement, and 12 leads ECG that was sent by GPS to a core lab for central analysis. And the results, this is the population, the division in female and male. As you can see, there was a high percentage of non-athletes, and between athletes, 33 were competitive and 67 non-competitive. And this slide shows also the risk factor, the distribution of risk factor, family history of cardiovascular disease, smoke, alcohol, and drug of abuse. And this is the results, normal ECG in 80%, 21% abnormal ECG. This is the distribution of the abnormalities, but when we use the more strict criteria, we observe the minor abnormal ECG findings, but the data, the most important data is there is not significant differences in non-athletes, non-competitive athletes, and competitive athletes. The same is for the major abnormal ECG findings with not significant differences between the three groups, non-athletes, non-competitive athletes, and competitive athletes. In the young people presenting an abnormal ECG, this underwent a second-level examination and third-level examination represented by echocardiography, ergometric test, ECG Holter, or Cepheic magnetic resonance imaging, and genetic test. From this examination, we diagnosed 6 students with Brugada syndrome, 4 dilated cardiomyopathy, 4 hypertrophic cardiomyopathy, 6 myocarditis. By genetic test, 6 students with long QT syndrome, and 6 accessory pathway ablation, 6 Wall Parkinson White. And we tried to calculate, we had no debt, and we tried to calculate the percentage of lives saved per year in our population, multiplying the incidence of sudden cardiac death in the disease that we diagnosed by the screening. And another point, I think, maybe very important point, who pays for the pre-participant screening? As you can see, this is the Canadian experience, but this is the same in Italy and in USA, and no public institution pay for this. One final point, the cost-efficacy of pre-participation evaluation. There are many approaches and many data on this. I would like to remember the results of Corrado and co-worker that demonstrated that adding a single ECG to history and physical examination at the participation entry will save 2.06 life years per 1,000 young athletes at the cost of 42,000 euros per life year saved. And I skipped this slide for time reason, but this is the procedure for calculating this cost. Some final consideration. Our research, I think, is the largest prospective ECG screening study in young population of post-puberty age. For the first time, competitive athletes, non-competitive athletes, and non-athletes ECG findings were compared. No significant differences were observed between competitive athletes and non-competitive athletes in terms of major and minor ECG abnormalities. The ECG analysis was entrusted to expert cardiologists, and current ECG criteria were considered. Moreover, during the follow-up, no death occurred. The ECG screening permitted the diagnosis of occult disease, which increased the risk of sudden cardiac death. The benefit of screening goes beyond the identification of the student risk of sudden cardiac death because it often triggers the evaluation of first-degree relatives who may also be at risk from inherited cardiac disease. Cardiac screening with ECG has the potential of saving additional lives. Thank you for your kind attention.